According to the CDC, approximately 1 out of 700 babies are born with Down syndrome each year. Down syndrome is a developmental disorder in which a person has an additional chromosome 21, which is called a trisomy. Down syndrome also has other difficulties such as craniofacial anomalies, learning difficulties, and speech impairments. Some common craniofacial anomalies include a flattened face, short neck, small ears, and tongue protrusion. A well-known risk factor is maternal age over 35 when the child is born. Other issues related to speech, language, and hearing include hearing loss, ear infections, and eye disease, which affect a large portion of children with Down syndrome, and these can affect long-term hearing and language development and speech. In this video, I will focus on hypokinetic dysarthria in this population because one study cited that not only is childhood dysarthria common in the Down syndrome population, but hypokinetic dysarthria specifically had the highest prevalence of the dysarthria types. Genetic changes may influence structural and functional changes of the central nervous system. As a result, degeneration of neurons can occur in the central nervous system, which leads to decreased cerebrum size, delayed CNS maturation, and decreased release of neurotransmitters. One study found that 97.8% of pediatric participants met the speech disorders classification system criteria for diagnosis of a speech sound disorder. Furthermore, many of the participants had childhood dysarthria or childhood dysarthria with another motor speech disorder. Only 26.7% of participants were classified as having no motor speech disorder. There are a few motor speech characteristics in children with Down syndrome, and these include abnormal rate of speech, irregular pacing and rhythm, decreased pitch range, decreased intensity, low muscle tone, and less rigid speech movements. Motor dysfunction in children with Down syndrome can be partially due to craniofacial anomalies, such as malformation of the hard palate and macroglossia, or a large tongue. Motor dysfunction common in this population can lead to changes in perceptual characteristics of speech, which includes imprecise articulation of consonants, hypernasality, irregular speech rate, prolonged silences and pauses, decreased vocal intensity perceived as loudness, abnormal oropharyngeal resonance, hoarse voice, reduced stress, and prolonging or drawing out sounds. Studies have shown that smaller cerebellum size is due to decreased white and gray matter, which is related to delays in motor skills and milestones common in Down syndrome. This is because the cerebellum plays a role in the rapid and precise movements needed for articulation. White matter is made of axons which transmit information, and gray matter is made of cell bodies. Therefore, there's less brain mass to transmit and process information needed for the motor control of speech. In summary, maturation delays and craniofacial anomalies contribute to the speech impairments present in the Down syndrome population. Furthermore, motor speech disorders are very prevalent in this population, with over 90% of participants in one study having a motor speech disorder. Deficits in motor speech control can be partially due to craniofacial anomalies, delays in motor development, and affects articulation, breath support, rhythm, and movement of the articulators. Motor dysfunction causes changes in the perceptual quality of speech, and common changes include hypernasality, hoarse voice, prolonged pauses, and imprecise articulation.